Good afternoon, and thank you for joining us for our Nelson Mandela University webinar entitled, When is the Peak? This is a question being continuously asked with various sets of data used to model and predict when South Africa's COVID-19 infections will reach their peak. COVID-19 has undoubtedly turned the world on its head, not least South Africa's metropolitan municipalities, which have emerged as the hotspots of the epidemic. Academics from the Nelson Mandela University in the Eastern Cape will share with us this afternoon their insights and thoughts around COVID-19 data models that seek to predict when the peak is most likely to hit us. We are encouraged that a wide audience is part of this webinar, giving us all more hope that the message is reaching many people and areas, and that education and information is indeed power. My name is Kwezi Mzilikazi, and I am the Director of Research Management at the Nelson Mandela University, but more importantly, a resident in Nelson Mandela Metro, Port Elizabeth. And this webinar talks in one way to the location and the broader public. We're joined this afternoon by colleagues on the panel who will present in this order. First, Professor Darrell van Groenen, then Professor Azwintini Moronga, and lastly, Professor Lungile Pepeta. Each presenter has been allocated 10 minutes. But before we get to our presenters, I'd like to go briefly over our rules of engagement. Firstly, please ensure that your microphones are turned off. Also, turn off your cameras. Use the chat section to ask questions and make comments so that you are an active participant. Kindly be respectful at all times. I will signal to the presenters when to start, and I will read questions and pose them to the panel as you request. This will be once all our presenters have had their opportunity to give their first inputs. Let us all be mindful of time, especially presenters. You each get 10 minutes for a start, and thank you everybody for your cooperation. We're looking forward to an interactive webinars. Our first speaker is Professor Darrell van Groenen. She is the Director of our Center for Community Technologies at the Nelson Mandela University. It's over to Darrell.
Good afternoon, everybody, and a very big thank you for this opportunity this afternoon to share some insights with you. I will start with a slightly more personal approach maybe to the issue of models, etc., and then my colleagues will move on to the more scientific elements thereof. So if I could ask our technical person to please share my slides. Right, so my topic this afternoon is more to do with COVID-19. How do we plan on models, act on data, and then also on the reality thereof? I think that what is very, very important for us is that in many ways, we do so many things just thinking about data models and all sorts of other things that we tend to forget about the actual human element that is involved in this. So I want to say for a moment, if we think back in the history of humanity, there's probably no data model that has been more recognizable than the COVID-19 infection and death curves. I make the statement there that virtually everyone from a farmer in India to the director of the CDC in the US is now familiar with all of these models. And there's probably not a person who does not know the word flattening the curve, the peak, and things like that. So I think that is really problematic in that sense, because never before have we been faced with that. So when we look at models, I want to just stop for a moment and say that from where I look at a model, they are probably our best guess estimates. So what does a model do? A model speaks to what we know, what we see, but more importantly, it needs to speak to the reality. So when we look at the whole pandemic of COVID-19, I think what is important to say is that South Africa needs to be guided by models in planning for the future. And I'm asking the question whether we are relying on actual data as we are using these models now. Because they are giving us a best guess estimate, the actual data we also know has its limitations and is based on, you know, what we know, what we live, and what we see. So we have many people who have now become experts on models, and that's with no reference to my esteemed colleagues on the panel. But who do we believe? We have very well established modelers that suggest that we will have at least 40,000 deaths and about 1.2 million symptomatic cases by September 2020. There are people who put even more horrendous statistics on the table, forecasting that a province like the Western Cape will be looking at 100,000 symptomatic cases by the end of July. Then we have others who assert confidently that South Africa will not even experience this level of COVID-19 related deaths, and that we will exceed maybe 5,000 to 10,000 as a result of the pandemic, but no more than that. So the question remains, who do we believe? So I want to make a few statements this afternoon, and that is to say that I believe sometimes models are used as a scare tactic or possibly a means to change the behavior. So the question is, instead of debating the accuracy of the model, should we not be asking whether the model in use is good enough for our specific scenario where we are at currently? We all know that in late April, the chair of the Health Ministry Advisory Committee Subcommittee on Public Health referred to some of the early models used by government as back-of-the-envelope calculations, saying that they were flawed and illogical and made wild assumptions. And I don't necessarily want to dwell on those, because I think we have moved beyond that. But I think what is important to note is that the information on the modeling was released much later, despite the apparently critical role that it had to play. So the question is, are these scare tactics, or were they used to change behavior? Maybe I can cast your memories back to the early days of the HIV epidemic. And we all know how long the HIV epidemic has been with us. So we can say that models are based on assumptions, and that we should consider what must be included and excluded from the reality. So my question is, what is our reality? When we think about the HIV epidemic, we can remember that in the early days thereof, some of the models assumed that every single country in this world would experience the same types of epidemics. It led to the estimates to say that over 5 million people will be infected in India. And we know now that the real number is fewer than half of that. So, can we generalize? Is it true that there's a one size fits all? So maybe if I can bring it a little bit home to the Eastern Cape, and then as Kwesi indicated, the Nelson Mandela Bay, let's look at what are our realities here on the ground in the Eastern Cape province, and then specifically in the Nelson Mandela Bay area. We have malnutrition and diseases, and we have many of those. This means that COVID-19 could potentially be more deadly in our region than elsewhere in the country. And we have seen an increase in some of these in recent times. On the right-hand side of my slide, you will see that there's an image of stunting in South Africa. Stunting speaks to malnutrition, and that is a very, very serious problem in the Eastern Cape province. I also know that in the last while, we know that we've had major issues with people not having enough food to eat. We already have a stunting problem. Can you imagine where that is now? We also have many comorbidities in the province. We have obesity, which is a very, very big problem in the Eastern Cape province and in the Nelson Mandela Bay area. Diabetes, high prevalence of diabetes, high prevalence of hypertension. And then, of course, not to mention the other comorbidities such as TB and cancer. The Eastern Cape province and the Nelson Mandela Bay area is home to many people who work in other parts of the countries. So we have unique situations whereby people go out of the province and young children remain at home with grandparents. In yesterday's news, there was a particular case that was mentioned of 180 learners in Mount Frere that were tested positively for COVID. What does that essentially mean for that society in that particular area? When we think 180 learners means 180 households, those households may comprise of elderly people that are actually very vulnerable because of their comorbidities. So how are we going to respond to this reality? How does that equate to the models that were developed in the UK, in Europe, in Italy, in Spain, in the US? If I move on and I look at our health systems, there are many other factors that we should consider. And one of the biggest questions that I probably have is, are we feeding our models with accurate number of cases, hospitalizations, deaths due to the coronavirus at a metro or provincial level? Or are people just being recorded as COVID-19 deaths, and possibly some of the deaths are related to the comorbidities and not necessarily to COVID-19? Or are we underreporting our COVID-19 deaths and basing it rather on comorbidities? So the question is, do we have complete data sets, or are we basing our assumptions on inaccurate data and false realities? Of course, the capacity to provide critical care in the Eastern Cape province is quite low. And we have severe forms of COVID-19 that leads to respiratory failure, requiring ventilation support. We require ICU beds in the province, etc. And I know that my colleague, Professor Pepeta, is going to touch on some of these issues as well. But I think it is important to note that our health systems, and specifically those in the Eastern Cape, are not necessarily ready to cope with this pandemic. Again, the question is asked, are we basing our models and our assumptions on our realities, or are we creating false realities in our society? So how do we go about changing behavior? And is the data that we are using, is that not dependent on behavior? I make the statement there that behavior produces data. Data feeds models. Models feed predictions. And predictions creates false realities. In our society, the South African society, the Eastern Cape society, but also the African society, social cohesion and social gatherings are of great importance. How do we change the behavior of people? We know that there has been a lot of discussion around the whole matter of funerals and how we deal with funerals in going forward, why there has been bans on that. So the question is, should our strategic approach not continue to focus on containment and aggressive preventative measures, which must focus on better understanding of the consequences of our behavior? Because again, our behavior will produce the data, will feed the models, and will create a false reality or a true reality, depending on what we do. So to return to the topic of our webinar this afternoon, how will we know when COVID-19 will peak? I think the African context, and then specifically South Africa and the Eastern Cape, is rather unique. The population structure is different. We have high prevalences of endemic diseases and double burdens of disease. So our health systems are stretched very thin with minimal critical care capacity. We need a robust COVID-19 response to take these factors into account. And this should include community engagement, health leadership, involvement of youth and religious leaders to drive containment. At a health system level, temporary repurposing and reorganizing of the surgical system will be key to us overcoming certain challenges that we are experiencing, and to ensure that we increase the critical care capacity during our response, and make sure that we have what we need to have as we move forward. And part of that, what we need to have, includes educating our people. So ladies and gentlemen, this afternoon, I want to say, when will the COVID-19 peak? The answer to that is, it really depends. It is in our hands, it is in your hands. How we behave will not only determine when it will peak, but be indicative of how and where it will peak. So in closing, I would like to thank you for being part of the webinar this afternoon, and I would say, please make your actions count, because it really does make a difference. Thank you very much, and I'm happy to take some questions later on. I will now hand back to my colleague Kwezi.
Thank you so much, Darrell. I'd like to remind our audience to keep those questions coming. There will be an opportunity to interact with all of our professors at the end of their presentations. Please also remember to keep tweeting. Our Twitter handle is @MandelaUni, and the hashtag is "It is in your hands." Hashtag "It is in your hands." So our next speaker to continue talking on the models is Professor Azwindini Moronga. He is our Executive Dean of the Faculty of Science. Prof. Moronga, it's over to you. Prof. Moronga, please remember to unmute your microphone.
Thank you very much, Kwezi, and good afternoon to the attendees. Thank you for giving me this opportunity and the platform to share some ideas about epidemiological models for COVID-19. I would like to share my slide. So thank you once again. I would like to also thank the colleagues who are my collaborators in some of the results that I will be presenting here as well. So epidemiological models have been with us for some time now. And we all know that infectious diseases are still a common cause of death in the world. The transmission interactions in populations are very complex, so we need to comprehend the large-scale dynamics of disease spread without the formal structure of mathematical model, which will be impossible. So we do need to have some models. An epidemiological model uses microscopic descriptions such as the role of infectious individuals to predict the macroscopic behavior of disease spread throughout the population. However, experiments with infectious disease spread in human populations are often impossible, and we know they are unethical and they are also expensive. The data is sometimes available from natural occurring epidemics or from natural incidents or endemic diseases. However, the data is often incomplete due to underreporting. This lack of reliable data makes accurate parameter estimation difficult, and it can only be possible to estimate a range of values for some parameters. Since repeatable experiments and accurate data are usually not available in epidemiology, mathematical models and computer simulations can be used to perform needed theoretical experiments, as I will show. So, since the outbreak of COVID-19, there has been many models suggested, some of them very helpful, some of them probably not helpful at all. And I'm going to go through some of these simple models that are in the market that could guide us to learn more about the COVID-19, especially here in South Africa and around the world. One of the simplest model that is in the market is the model which is known as SIR model. And this is the susceptible, infectious, and recovery model. This is where you compartmentalize groups of population in compartments of those who are susceptible to the disease, and then they will get infected, and when they get infected, they can recover. However, this is the simplest model. And if you look at the bottom right of my screen, you will see that you can actually make the model complex and complicated by adding demographics, by adding either quarantine measures, by adding either lockdown measures. You can even add in the population that there are people who are born and there are people who will die eventually. You can put all sorts of other measures within the model to make it complicated. However, for the sake of this presentation, I would like to go to a simple model that has been used and that we have been studying ourselves and reporting on some results. It is known as the D model. I'm going to use this as sort of as an example of a COVID-19 model that is used. And this model has got some assumption. And one of the assumptions is that during COVID-19, the recovery rate is very low. And in that case, it can almost be neglected. And if you do that, the model becomes very simple because you will have reasonably assumed that the spreading time of the pandemic is much, much faster than the recovery time. And the question will be, is this what we are seeing? Is the recovery time really much slower than the spread of the pandemic? And if the answer is yes, then this model will or should be relevant. And this model has been used by my collaborators to look at what has been happening in China. And on the panel on the left, you could see the reported death in China. And you will see that the model, of course, does feed the data with the parameters that you can extract from the model. And on the right, you will see that the model again is trying to look at the data that is presented and try to feed the data. And this was way back in China just after the outbreak. And we have a lot of lessons from other countries in employing such a model, where you can see that different models could explain the uphill, and when it comes to downhill, which is an indication of the different measures put by different countries. And this is where you have to put in the model what the countries did. Did they have lockdown? Did they quarantine people? So that you can reproduce the data that is being presented on a daily basis. And then coming to South Africa, we started looking at our case in South Africa, and you can see that we are still climbing the hill at around June 15. And if you look down, you will see that around June 19, we were almost, according to the model, almost climbing the top of the hill. I have to say that the top of the hill here is only an indication of the reported death. It's not the number of those who have been infected. And as we stand as of today, this is the picture as we follow the model since June 3rd up to today, looking at the reported death rates that are coming every day. And you will remember that I have made an assumption, or I have stated an assumption that is made in the model. And therefore the model is looking at only the reported case of the death rate and the death number per day. And this number, therefore, has to be reliable as compared to the number of infected patients, simply because these are reported coming from hospitals and elsewhere. And these numbers are more reliable in terms of the data compared to the number of those who have been infected due to testing and screening. So, and here is another graph that is comparing our situation in South Africa as compared to the USA and Argentina. And my collaborator, Nico Ostrom, the University of Western Cape, sent this to me last night. And I thought this was fascinating. It's using the same model, which is the B model. I thought it was fascinating to look at the two countries, Argentina and ourselves, and look at the population and look at what is it that they did, and to look at where are the hotspots in these two different countries, and therefore to start asking ourselves questions. Why did Argentina start to level off or flatten that curve of the number of deaths way ahead of us? And these are the questions that we might debate in terms of socio-economics of these different countries. We have learned some lessons through looking in these models, that there are challenges in epidemiological modeling. This is a very complex system which involves many degrees of freedom and millions of people. And the question still remains, can any model predict the evolution of an epidemic from partial data? At the moment, what we have from South Africa is partial data that we are following. Previous pandemics can help us to understand the current COVID-19 pandemic. And the modeling of this COVID-19 will help humanity to be better prepared in the future. In the end, it is in your hands, and the fight against COVID-19 continues. I would like to take this opportunity to thank Kwezi and the organizers for giving me the platform. And also, I would like to thank those who are in attendance. And I will take questions during the question and answer session. Over to you, Kwezi.
Thank you very much, Azwi, for brilliant timekeeping. I'd like to remind our audience again to continue tweeting. I've been seeing those questions coming through fast and furious. Thank you very much for those. We're going to start publishing them so that our presenters can see them and they can start to think about how they want to engage at the end of the presentation session. Our Twitter handle is @MandelaUni. And the hashtag is "It is in your hands." Hashtag "It is in your hands." We're going to switch gears here a little bit by inviting our Executive Dean of Health Sciences, Professor Lungile Pepeta, to give us the clinical picture of the epidemic. Over to you, Lungile.
Thank you very much, Kwezi, and thank you very much to the audience. Yeah, now let me just look at what the clinical picture is like regarding this pandemic and what we are seeing on the horizon. In other words, the tsunami. So then we're going to look briefly at the structure of the virus itself. Sorry to bore you if you're familiar with this picture. If you are not familiar, please do not get scared. It is just a picture that shows that the virus is an RNA virus. This is the genetic material inside the virus, which classifies it as coronavirus. And this virus, which is an RNA virus, is actually belongs to a group of coronaviruses, which include the severe acute respiratory syndrome virus, the Middle East respiratory syndrome virus that we are familiar with. So we have had a SARS virus before, and this one is called the novel SARS virus, or SARS-CoV-2, the COVID-19 virus. And because there are many coronaviruses that we have been exposed to, which is why it's important to understand that aspect of things in terms of testing. And I do know there have been questions around testing in terms of saying, why can't we use rapid tests? The issue with that is cross-reactivity with the other coronaviruses that our bodies have been exposed to. Because of that, then we may get false positive results. In other words, you might be diagnosed with coronavirus when you're actually not infected with the novel coronavirus. The other aspect of things is that if you have coronavirus and you have it in your body in much lower doses, that in fact you are asymptomatic, you also may not mount enough antibodies against the virus to be able to test positive. And as such, you may get a false negative result whilst in fact harboring the virus. So let us look at global trends again. These are the recent figures that we know across the world. We are familiar with them. We have very high numbers that we can see as of last night. We got more than 3 million active cases out of a total of 9.3 million that we've had. But if we look at this graph, right at the bottom is the incidence in Africa. But the main thing about this is that we may think that we don't have cases in Africa. No, we have challenges with testing in Africa. That's why we may not be able to record all the cases that we see. So those blue bars show the cases that are in Africa. But of interest as well, you might notice that in countries where we're able to test, our graph is maintaining the same global trend of increasing numbers. The hotspot countries at the moment is South Africa, followed by Egypt. So those are the countries. And also, like I said earlier on, I guess it is due to the fact that we're able to test in these countries more than the others. Bringing closer to home, and we're familiar again with these, if we look at the South African incidence as of last night, we have about 106,000 cases and our death rate is just over 2,000 patients. But again, we have an exponential rise in our cases, just to emphasize that. And in the Eastern Cape, on the 22nd of June, we saw 17,000 cases. And then bringing it closer to Nelson Mandela Bay municipality, if we look at April, right back there, when we're still on level 5, we had low transmission rate of COVID-19. Somehow that picked up during level 4, and now in level 3, we have I can confirm with you that cases per day now in the Bay are more than 300, and we did have more than 400 yesterday alone. So what is the meaning of this when we look at the trajectory in deaths? This is presenting another graph that was adapted from London, and this graph shows the number of deaths that when we look at South Africa and compare it with the previous data from South Korea, the previous data from the US, the United Kingdom, you can see that South Africa, though a late starter, is rising exponentially in terms of the death rate. And the death rate, if now we double our death rates every 10 days, we will notice then that in no time, if we look after 20 days, we will be sitting at cases approaching 10,000 in terms of the death rate. And this would be in keeping with the graph that was shown by Professor Muronga just now. Now, just talking about these numbers and what we are seeing when it comes to the cases that we have, if I am to go back and explain one principle, if we are looking at the cases that we have in the Bay, and we are reporting that on the 23rd of June, we had about 5,300 cases. It is stated that not everyone can reach testing, and therefore we may not be able to reach and diagnose everyone with COVID-19, but there will be those cases that go undetected. What is the infection rate of COVID-19? Every individual that has COVID-19 can spread it to 2 other individuals, and that's how the disease is spreading. So initially, the spread will be slow, but as we pick up the numbers of the infected, that number just continue to rise at an exponential level. So if then we are looking at that, that's the infection rate. But also, if we concentrate on testing, 5,300, it is stated that there are 3 to 5 times individuals that may be walking around with COVID-19. So if you multiply 5.3 by 5, you get to close to 30,000. So the real figures might be sitting around 30,000 of individuals that are infected with COVID-19 in the Bay as we speak at this stage. So if you see a figure of COVID-19, you multiply that by 3 to 5 times to check whether, in fact, what would be, to estimate the actual number at ground level, where you may not be able to actually test the individual. So what are we looking at in terms of how clinically the disease progresses and how that affects the clinical space in terms of the presentation of symptoms and the need for hospitalization, and of course, the unwanted outcome of demise or recovery. So you notice that you'd have, let us say, like in this graph, you have an infection on day 1, the 22nd of March, majority of patients would recover and they would have no symptoms, or they'll have mild disease. So about 80% of patients with COVID-19 will have no symptoms or will have mild disease, which is fever and cough. But then those with no symptoms will have had the infection and would have recovered. So if you have no symptoms, this is particularly important if we're talking about someone who's been a contact. If you have no symptoms and you've been a contact by end of day 5, it's highly unlikely then that you're gonna run into trouble and develop disease later. Or you may have mild symptoms, which may go on for about 14 days, which is why it's usually recommended if you are symptomatic, you can return to work after 14 days after the disappearance of symptoms, because at that stage, your infectivity level is very low. But then you may start with severe disease, which involves breathlessness. Once you have that, you might then present to hospital, and this starts on the 3rd week of the disease, being severe symptoms, which require oxygenation in hospital. And some of those patients, so that group that is up there is a big group, 15 to 20%, but it is a very small proportion of patients that would require ICU and require ventilation. So they say 3 to 5% of the population will require ICU. But then the death rate out of that is very high for patients that are in ICU. Out of a total population itself, the death rate is really low. It is around 2%. But out of those that make it to ICU, the death rate is extremely high, reaching between 70 and 90% of patients that get into ICU. So the recovery is very, very slim when it comes to patients that go to ICU. So what does that mean? How many patients will end up in ICU? If we are looking at the actual ventilated patients of 1 to 2%, we are looking in our population that now sits around 5,000, and 1% of that is 50 patients. If now you check the statistics in the Bay, that is so accurate, of the diagnosed patients, there are 49 COVID-19 positive cases that are in ICU today. Now, with a doubling rate of 10 days, it means in 10 days' time, and the way at which we are going, we would require 100 beds, which we don't have. Professor Van Kroenen mentioned the issue of resources and as to how we're going to deal with this. How are we going to get the human resource to nurse those patients that now require 100 beds? We might have 100 beds in terms of infrastructure, as you are aware, but who's going to run it? Who's going to stand at bedside and manage those patients is the question. The question of resources, the question of imbalance, of an imbalance in resources becomes a very, very real one. And therefore, no matter what we say, it is in our hands. The low-hanging fruit is to prevent the spread of COVID-19. Otherwise, majority of us shall fall victims to this disease. Thank you very much. I will be taking questions later. Thank you, President.
Kwesi, unmute.
Okay. Thank you very much, and my apologies for speaking while muted. Thank you very much for that sobering picture that you've just painted for us, Lungile. We have received quite a few questions in response to all the three presentations. And what I've attempted to do is, just as a first round, to cluster them into questions around the data that goes into the modeling. So a few have come out. So I think I will specifically address these to Azri. In models like these, how does one take into account one variable, behavior? So that seems to be coming out quite a lot, how the models account for behavior. An example is made of the US, where initially they had a downward trend with regards to the infections, but these seem to have picked up and are increasing dramatically again. The second one around the information that goes into the models is how do the models account for cluster outbreaks, for example, in funerals or at school. The other element that's come through is how do the models account for interprovincial transmission, as the Eastern Cape outbreak closely mirrors the Western Cape. So, and then there was another one also about age. Age has been listed as a high-risk factor. To what degree is this factor relevant in the Eastern Cape and Nelson Mandela Bay? And lastly, how undernutrition is also accounted for in these models. So these are just some of the ideas and some of the parameters that people think would have an impact and an influence on the model. So while you think around that, I think I'm just going to pick around what Darrell said earlier on. And Darrell, I really liked the statement that you made where you said behavior produces data, data feeds the models, and the models construct our reality. I'm just wondering about the reality around this, where people may have information, but out of sheer necessity, for example, one of the behaviors is to minimize your moving around. But simply out of the economic realities, people are simply not able not to move. If you're thinking about your street vendor, if you're thinking about your taxi operator, and many other people that need to be in business, especially given how many businesses have actually closed down during the lockdown period, which was primarily aimed at minimizing movement. So how do we account for those economic realities versus the behaviors in and of themselves? So while Darrell thinks about that, Darrell, you can also think about the two questions that I sent earlier on. I'll give over to Azwi to start talking to the parameters that go into the models.
Thank you very much, Kwezi. Yes, as I've mentioned, the assumptions that went into the model is very simple. However, I've indicated that one could add in these other variables. In order to do that, which means the model has to ask these questions itself in the data. So for example, it will have to say, give us the data by age. We want to see those death numbers by age, so that we can also therefore input it. So it's easy to input it, but if the data is coming already averaging those behaviors, then you will not be able to extract that. So you need the data already coming in that form, and which I think is available to do that. But at the moment, we just given the total numbers that we have. One can go in and dissect the data. But however, also the other variables like interprovincial. So the data didn't take that into account because it just looked into the population, which is in terms of mixing homogeneous. And that could also be taken into while you dissect by province and districts. And it will mean that within your model, you will have to allow for people to travel from districts to other districts and build that into the model. So that can be done. But at the moment, the model is only looking at the overall average numbers. Thanks, Kwezi.
Thank you very much, Azwi. Another one that has come through, and between Lungile and yourself, you can decide, because I'm not familiar with this question, but it says, with regards to case fatality ratios, what is your opinion on the Kaplan-Meier method, which was validated using SARS in 2013?
Come again. I didn't hear the method that.
It's called Kaplan-Meier, and it was validated using SARS in 2013, and it relates to case fatality ratios. So they're just asking for your views on that. Either one of you, whether it's you or Lungile, can take it.
Okay, so I would like to know more on that validated method myself, because we haven't taken that into account. Perhaps Lungile will know.
Okay, so may I make a suggestion here? So our member of the audience that sent through that very specialized question, could you send through a little bit more information about how the method works, and then we'll pick up on this later. All right, Darrell, now I am going to turn my attention over to you to speak to the realities of our people in terms of how their behavior produces the data that we put into our models, but how that very same behavior may be difficult to change based on realities.
Thank you, Kwezi. And yes, I think a lot of the issues that have been raised by the audience are the things that speak to the very hearts and the daily lives of people. At the moment, a lot of the hype around COVID speaks to statistics and data and so forth, and I fear that sometimes we reduce the everyday lives of people to numbers and stats. And I think that's a very dangerous thing to do, because we have a very strong human element that we need to consider. So I want to stand back a little bit and just have a look and say that some of the questions that I've seen that have come through speak to the question that people do not want to be tested or don't want their test results known because they are alienated, isolated, and so forth. And then I will come to what you spoke to about the restriction of movement and so forth. I think that we need to remember that this disease, like any other major disease, is an unknown, and it brings about fear in people. And we all fear the unknown, and therefore the strong message that we need to bring across is that the stigma that we are subconsciously attaching to this is not necessary, and that there's a strong element of education of our people that is needed. I, for example, let me use myself as an example. I move around in the public healthcare facilities at the moment quite a bit because we're busy with the ICT solutions and so forth. So people are constantly asking me, are you not scared that you're going to be COVID positive? Or they don't want to come too close to me because I have been in and amongst that, and I'm sure Lungile has a similar experience. So my immediate answer is, but I have a very specific regime that I do when I come home, clothes that I take off, how I sanitize, wash my hands, make sure that I wear disposable masks and things like that. And I think it's all to do with education and ensuring that we really truly understand the nature of what we need to do. So in opening up the economy, as we all, and I'm curious to know what our Minister of Finance is saying at the moment, because it's the budget speech that's happening as well, and what the implications are going to be in terms of the economy, and we know it's not going to be positive. So in order to open this up more, we need to take a very positive stance on understanding what the impact of our behavior will be. So when you go out into the streets and you see how people play around without wearing their facial masks, without washing their hands and things like that, what is the implication of that? So that's why I say our behavior feeds into the interactions and into the data. So if we do not change our behavior, then we may as well just open up the economy, lift all the restrictions, and off we go and face the consequences of this. So I think, to me, it is a question of fear of the unknown. How do we address that fear of the unknown? By getting more knowledge and information. And there's a lot of knowledge and information available. And now I also want to extend the invitation to the public watching this webinar to approach the university, because we have massive repositories of information that we are making available to share. And I'm sure that our communications department will be more than happy to oblige in terms of that. I will return to some of the other questions, but let me first give the colleagues some opportunity to respond to the Kaplan-Meier question before that goes out of mind, and then I'll come back.
Prof. Pepeta, I think you can take this one. Thank you very much. A little more information has now come through. So Lungile, please go ahead.
Thank you very much, Kwezi, for that, and thank you for the question. Yeah, the Kaplan-Meier estimate of mortality or survival has been used a lot in medical literature, and we apply it all the time to determine the rate of survival over time. So we usually look at the patients surviving divided by the patients that are at risk, and therefore are able to state the survival rate when it comes to a particular risk, which in this case is COVID-19, and therefore are able to say how many people live when they've been infected with a coronavirus. In reverse to that, we are able then to tell how many die. As we know now, the global mortality rate using these basic calculations is sitting at around just above 5%. So the survival rate is really around 95% when we look at COVID-19. And the Kaplan-Meier models or curves can then be applied to determine these rates, and they are very reliable. Thank you, Chris.
Thank you very much, Lungile. There's another question that's come through from Professor Mbanga here. And he's basically concerned about modeling that's done on a big scale and applied at a smaller scale. So what system requirements, for example, skills and infrastructure, is required to at least decentralize epidemiological modeling to provincial and metro level to determine when the peak will hit us? Partial data-based models that are at bigger scale sound crudely misleading. So maybe what's happening at the macro level is not necessarily applicable to us here in the metro. So what can we do? And I think both, I'll start with Darrell. What can we do to decentralize and make sure that our models actually speak to our own reality within the metro in the Eastern Cape?
Thank you, Kwezi, and thank you, SJ, for that question. I think maybe just something that is necessary to share with the audience is that there's a major collaboration behind the scenes between our industries in the Eastern Cape, but not only in the Eastern Cape, further afield as well, together with government and academic partners to put the correct infrastructure and skills in place to ensure that we are able to now decentralize our data, and that what we are reporting on is relevant to our very own scenario and situation here. So we are now able to, slowly but surely, it's taken a while, and I think I have to also say that in fairness, when it comes to these kinds of solutions, it's not just a press of a button or three. It takes a while to understand what it is that we're dealing with. So over time, a lot has been happening behind the scenes, and in the next few days, the general public will see the culmination of all the efforts coming together and decentralizing the information so that it becomes relevant to our very own metro, and that we can see and make predictions based on the realities that we are facing here now. So the short answer is there are system requirements. We understand what those are, and they are being put into place, and they will go live next week.
Okay. Next week sounds great, Darrell. Another question that's come through is in terms of community engagement, and perhaps I can direct this one to Lugile, because in your opinion piece yesterday, Prof. Pepeta, you were quite vocal about what we need to do and getting all hands on deck. And so the question is really around community engagement and youth involvement. Why is there a gap in the involvement of the private sector? What can be done to ensure more private sector involvement? Since Prof clearly stated, and this was Darrell, that the Eastern Cape has stunting as a result of malnutrition, and according to Stats SA, the Eastern Cape is the poorest province in the country. It is important that this type of robust response is activated. We need the resources of the private sector to help flatten the curve. So that's both a comment and a question. So basically, what can be done to ensure more private sector involvement in the response to COVID?
Thank you so much for that question, Kwezi. This is the question I'm asking, as you know, as well. We, at this point in time, this is not the time for you and me, and I'm here and you are there. This is the time to actually come together, unify, and fight a common cause. We need leadership to give us guidance how we can do this, number one. Number two, we need political will, therefore, and then we need willingness amongst the stakeholders that need to engage in this. My concern, you see, as university, we want to be part of this, we want to be in this space, but then there must be willingness from the private sector. There must be willingness from the business sector. There must be willingness from the municipality. There must be willingness from the community. It is high time that we even involved structures like our unions, like our community leaders, like our youth leaders, but also operationalize the issue of COVID-19 management, both at a medical level, but also as an educational project. All the issues that Darrell was raising around behavioral change, around educating society, around involving society, around involving the youth. The youth, much as they won't get much disease in terms of symptomatic presentation, but they shall transmit the virus when they are infected, and they are most active. And that is worrying if they are not aware that then that is. A good example is the about 200 children in Mount Frere that have tested positive with COVID-19. Majority of them won't have disease, but we don't know if they were to come in contact with their families, the adults in that household that might get COVID-19 and all those other issues. But that boils down to education, to behavioral change, to trying and eliminate the disease. The virus doesn't move, we move it. That comes as part of education as well. We don't have enough resources to save the lives of those that we are seeing perish because of COVID-19. Whether you think you have a premium medical or you don't, at this point in time, it will boil down as to whether we have beds in the bay or not. And if you don't have beds, sorry, you'll just be in a corner somewhere and perish. And this requires concerted effort now, not yesterday, now. So that's the key at operational level, not high-level strategic meetings that sit once a week, once every 2 weeks. That's not going to help us. That's not how you manage a health emergency. We need to declare a state of emergency at this point. Thank you.
All right, Prof. Pepeta. My question is a simple one. Why is the message not getting through? I have a comment here from Linda Jackson who says, I have experienced people not wanting their COVID status known by fellow workers and not wanting to stay away from work even when not feeling well or when told to stay away from work after being tested and waiting for the results. Why is this? Do people not want to be isolated by their community, or is there another reason? So it seems those who are not sick and those that are sick, nobody seems to want to do the right thing. What is going on?
There's various contributing factors to this. The one is lack of education about the virus. The second one is stigmatization of the virus. The third one is perceived or real ill treatment that people receive if they are to be isolated in all these facilities that are being provided. I am saying perceived because some of them may not have experienced it, but there are those that have experienced ill treatment and have reported it, and they are complaining about the conditions where they must live under if they are isolated. Those are the realities, and that brings in the issue of systems failure. And that brings in a disjointed effort towards fighting COVID-19. So all those things, people worry to be separated from their families, to go somewhere. And some have not even seen the stadium. And the stadium is really a very beautiful facility. I've seen it myself. But there might be other accommodation spaces that are not conducive in terms of them being provided for quarantine or isolation. And people don't want to do that. The other issue is victimization at work, whereby if you are COVID-19, you stay away and then you are not paid your benefits if you declare it, and then you lose on income. And we must realize that that is happening as well, and it should not be. So all those factors contribute to people, and we just need to educate ourselves, employees, employers, society, about all these issues. And we need to understand, again, prevention of COVID-19 spread is key. If you are keeping quiet and you know you are positive, you might be infecting other patients, and that's equal to murder. And people now must understand what that means, because they might survive. But what if they come across a vulnerable, high-risk individual who's not going to make it and gets infected by the very same people who are hiding their status? There are those things that we need to educate our society. Thank you.
All right. Thank you very much for that. Prof. Moronga, I want to bring you back into this conversation because the crux of our webinar is, when will the peak hit us? That is what we want to know. So in South Africa currently, we have lifted the restrictions from level 5. We're now down to level 3, even though the number of cases is increasing weekly. Are there any data models that estimate when we will reach the herd immunity that is often spoken of, so around 70% of the population? Do we sort of have an idea of when we might get there?
Thanks, Kwezi. Yes, there are models in South Africa where people have been predicting, as you have seen in print media, various numbers, some large numbers, some small numbers, and it depends on what you have put in the model. Some people are asking, have you included that winter is coming, for example? So it really it's a moving target as we speak. Perhaps what we need to learn is to learn from other countries as well. And the reason why I'm saying we need to learn from other countries is because these are interventions. And these interventions, if you look at what I've presented, you will see at the downhill that the simple model could not actually fit the data. And the reason for that is because the simple model assumes this homogeneity within the model, that everything is just, people are just interacting, transmitting, and that's it. And if you don't take into account that at some point countries wake up and they say, hey, we need to do something. And that's why in those plots you start to see, as you go down the hill, there were bumps and this and that. Those are the indications of interventions by countries, which means we will see in the long run the effect of South Africa's interventions. And actually, we already started to see it. If you look at the death per day in South Africa, as it climbs the peak, there was a red curve. And that red curve is indicating that has South Africa not done what it has done, we will have follow the exponential curve. So it therefore also means that in terms of predicting the peak, one has to say it is still pretty much in our own hands. We can really make the peak very big, or we can actually reduce it by actually following the protocols that Prof. Peter and Prof. Van Kronen is actually alluding to. So hence I will say the peak is in our hands.
That reminds me, please do not forget to keep tweeting our hashtag, it is in your hands. Darrell, let me bring you in here. How are our academic institutions proactively supporting government to stem the tide, in addition to focusing mainly on clinical care?
Thank you, Kwezi, and I think that's a very, very important question, because as academic institutions and specifically universities, we are in service of our societies. And I think maybe for just a moment, let me also just focus on what our own university is doing and how we are converging with our communities through our various task teams that we have formed, whereby we are interacting with civil society organizations to ensure that we reconstruct some of the pillars of civil society that may have gone lost in our modern day and age that we live in. So at Mandela University, we are doing quite a bit of work in that space, and I'm not going to elaborate, but I would invite you to please go and visit the COVID-19 website of the university, because a lot of this work is outlined there. But at a higher level, there are many different areas in which academic institutions are supporting government and working with private sector and other industries to ensure that we respond to this. Probably one of the most recent examples in our own midst here in the Bay is that of our newly opened field hospital that was opened by Minister Mkhize yesterday, whereby we are collaborating as a university to ensure that the correct infrastructure, from the right PPEs to ventilators to all of that, through our engineers, our Mask Up campaign, all of those have participated in ensuring that we are adequately prepared to set up facilities like a field hospital. And then, of course, from my own perspective, the ICT solutions as well. But I think what is important, and I want to just mention whilst I'm on the topic of the field hospital, this is a specialized facility that is put up at life speed, because as Prof. Moronga has just said, the peak is in our hands. And I also want to assure people that we now are actually being prepared in the Bay to deal with this peak because of facilities like the field hospital that is equipped with ventilators, isolation facilities. The same goes for the stadium, etc. Also at other levels, academic institutions, and it's all over the news, where you will see different academic institutions are doing different solutions, not only on the clinical side, but also on the data modeling side, on inputting data, on production of specific materials, ventilators, etc. So I think there's a lot of cutting edge work that is being done that's maybe not as widely publicized as what it should be, because as we've come to say, everything has to happen at life speed. And I think, again, the invitation is there to members of the public to also put up their hands and say, you know, we are happy to join in this whole fight against COVID-19.
Thank you very much, Darrell. Lukile, when it comes to how the government is dealing with the COVID situation, especially around the lifting of restrictions at the different levels of lockdown, people have been referring a lot to the Swedish model. And a question has come through as to whether could this actually be a strategy of the South African government? Is that why we are progressively moving lower and lower in the lockdown levels? We're at 5, we're now at 3. Are we trying to emulate what the Swedes did? And if yes, can you please comment on that approach from a health profession's point of view?
Yeah, and I was expecting this question. I don't think the government is adopting the Swedish approach. For number one, we are a middle-income country. Sweden is a first-world country, and they could afford to sustain their society and their community and its livelihood more than South Africa. And you did allude to this earlier on, and Darrell mentioned it as well. So it's going to be very difficult to think that we're going to be able to continue feeding our society for 4 months, for 6 months on lockdown, and we're still on a level 5 lockdown. That is going to be an issue, and we're already seeing an uprise from poor communities about them going hungry, about them having quite a number of challenges. Number two, there was a mention of malnutrition, which is a reality in the setting, in our setting, where people have no resource. And the sad part about that, Darrell, as you asked the question around that, is are we even aware of the extent of this? We shall never know, unfortunately, because we are not looking at that statistics at this point in time as to how many people, whether affected by COVID-19 or not, have demised from malnutrition. We shall never know that statistic. But the other reality, Kwezi, is that there is a lot of other diseases that now have been put on the back burner, and they need to be attended to. So we need to open up to those as well and say, how do we respond to that? And we will never know the impact of COVID-19 on those. But I don't think as South Africa, we are following the Swedish model. We are just forced by our socio-economic situation to open up the market. And it might be that this is happening prematurely. But here is another very, very important point I want to make. Had we all adhered to the lockdown rules, we wouldn't be here now. Now, I know that one might say it's easy for you to say this, Professor, in your own house that has got all amenities. That is another reality that one needs to face that. Perhaps in other areas, it was exceedingly difficult to observe the rules of lockdown 5. But be that as it may, it does appear like if we want to self-sustain, self-preserve as South Africans, we need to go back to the basics, even if we are relaxing lockdown, because life must continue. That's the bottom line. Thank you for it.
Thank you very much. Thank you very much, Lungile, for that question. Another question that comes up, and I know you've got views on, is the one around testing and who should be tested and how much testing should be done. Because in the Western Cape, for example, they are only testing people are above 55 at the state facilities, and you only get tested if you are under 55, provided you have your own private health care. What is the thinking around this, and what is the correct approach to testing, or is there even a correct approach to testing?
Yeah, you see, thank you for that question, Kwezi, and yes, I do have my views around that. Coronavirus is a virus that has got no cure. If you have it, you got to receive supportive treatment. It has no cure. There is no medication that you're gonna be getting and it will eradicate the virus. Your body and many other factors need to deal with the virus. If there is superimposed infection or there's a system in your body that is failing, has to be supported, but the treatment itself is not targeted at curing the virus. Now, I have mentioned that majority of patients, about 80%, either they will have no symptoms or they'll be having mild symptoms, and they will be fine after 14 days of having COVID-19. I am wondering if you are asymptomatic or you have mild disease not requiring hospitalization, as to why are we spending so much resources which we don't have to test you, rather than focus on those that are severe, requiring hospitalization, and are high risk. So high risk is older than Cape Town says 55, I may be saying 60, following the CDC and World Health Organization, and also comorbidity. If you have cancer, if you have hypertension, if you have any other condition that compromises your immune system. And even if you are HIV positive, if your viral load is suppressed and your CD4 count is high, above 350, you are not at high risk. In fact, we need to do a study and see whether antiretrovirals, what do they do to this COVID-19, because there are trials now that are being done using the same antiretrovirals to treat COVID-19. So for me, testing should be limited. We should not be chasing testing. If you are asymptomatic and you are a contact, if you are isolated for 7 days and you have no symptoms, you should come back to work, because you will never be spreading the virus, as per that graph that I showed. If you have symptoms, then you may spread the virus up to even 14 days from the last day of your symptoms. And then that's why that 14 days is recommended if you are symptomatic. And then, of course, if you have severe disease, you are in hospital, that is when you must test. That is the education that we must put out there about this virus. The fundamental issue about it is that whoever is around you for the next 24 months, even, as we are saying, you need to treat that person as a possible COVID-19 positive individual. Whether it's your best friend and you haven't seen them in years, love them where they are. Thank you.
Thank you very much, Dean of Health Sciences. I know you're very passionate about this aspect of testing. A very important question has just come through, and this one says, perhaps we can start to think around this. What are some of the big questions and lessons that COVID-19 is or has taught us about the state of our public health care systems? What are some of the fundamental changes that will have to be realized? What will it take for us to have a drastic overhaul of the manner in which we view public health? What is COVID teaching us?
It is exposing what we already know, that we needed, because we've been saying it all these years, that we need to improve the nature of the public health facilities. Right from infrastructure to equipment to HR for health, human resources for health, and all those. We do know that we have far fewer numbers of nurses per population, far fewer numbers of doctors per population, far fewer numbers of support staff and services per population in this country. And these figures we know very well. And also it teaches us to change the way we deliver healthcare in this country. Go for a more comprehensive and yet affordable healthcare system than a curative, predominantly curative system. We cannot, as a low and middle income country, behave as if we are the first world. We just can't have ivory tower hospitals without focusing on, if we had focused on disease, health promotion, disease prevention, treatment, rehabilitation, and palliation, and afforded all these parameters the same importance as treatment, we wouldn't be here today. We wouldn't have transmitted COVID-19 the way we are doing. Had we maintained basic, simple personal hygiene, we wouldn't be here today. In fact, we wouldn't be here with many other diseases. And we are a high middle income country, by the way. Why are we not changing the way the health system functions? Concentrate on primary health care. Our general practitioners teach our patients about good health and well-being rather than prescribing the whole pharmacy of drugs for hypertension, for diabetes, for instance. All those things, lifestyle modification, that's where our system needs to concentrate on. A decentralized primary healthcare system, which is about education, which is about follow-up of patients, which is about promoting, taking good care of yourself. A system that says at least once a year or twice a year, I must go for a checkup, for instance. That's what this disease is teaching. Thank you, please.
Thanks, Lungile. Azwi, let me bring you back here. So I've always wanted to use this sentence. We have a question from Anonymous. And Anonymous says, I understand the COVID-19 peak is in our hands. So that message seems to be going through. It is in our hands. But can the current data and models show us a focus of when we will hit the peak in terms of the numbers infected? So if we did the right things, if it's really in our hands and we did the right things, will we see a peak or will we see a decline?
It goes back to, if you've got a homogeneous system, say we are under lockdown level 5. Now nobody's going to the villages to infect the people in the villages, and it has spread in those hotspots. Then that becomes your population, and it's a controlled population. Therefore, you can just say, you can estimate, said, if everybody is infected, and given what is the fatality rate, therefore this is how it will peak. And now that you have opened these other levels, then you have opened another window of which the models have to now take into account of those, and you can only rely on the data that is coming. If you look at the figures and the plots that I've indicated there, we started modeling and looking at this simple model from around June when we went into a new lockdown, and since then that model has predicted between end of June to mid of July. And you have seen, and I saw another question which was asking about the plateau. So, but that is only coming from the data that we have. And maybe let me remind colleagues and those who are in attendance what those data means. It means you're looking at 20 to 30 days ago, somebody who have been infected 20 to 30 days ago, and they've passed on now. So you have to take that into account, and that was taken into account in the model. So that model is telling you the measures that we had then, and therefore perhaps for me, I'm saying we haven't seen the impact of the level 3 yet, because those who are getting infected now, the numbers therefore might surprise you towards the end. So that question is fair. Had things remained, therefore the peak is predicted between end of June and middle of July. Thank you, Kwezi.
Thank you very much, Lungile. I'm gonna come back to you on this one. As a healthcare practitioner yourself, we have our people that are at the front lines of fighting the battle. And the question is, what contingencies do we have in place to support the nursing staff? Do we not have enough nurses to deal with the normal, or rather we do not have enough nurses to deal with the normal healthcare requirements? Now we demand even more from nurses. Isn't there anybody we can call on for assistance? For example, the Defence Force.
Yes, in fact, that did cross my mind. It was raised by my friend at another meeting, Laura Pets. That would be a very good resource right now. We need all hands on deck at this point in time. We need the military to be involved, whatever skills they are bringing, and we will do the upgrading, train them on the ICT systems that they must use to capture data, to capture nodes, train them on the care of patients, train them on various set of skills that are needed. This is for me a state of emergency. We do need that. But also tap on the institutions of higher learning. Tap on the colleges that train health practitioners like nurses, for instance. A nurse in third year, fourth year can manage a critically ill patient very well because they are right towards the exit in their training. A little bit of training around those areas will go a long way. Look at the colleges and the universities that train emergency medical care guys, for example, and all other clinical guys that are out there to train them. But fundamentally, and this is very important, provide all the health practitioners and the students that you are inviting to be part of this agenda personal protective equipment. We do not want to expose them to danger. This is very, very key. Now, if this was another kind of disease and it was not attacking the seasoned senior citizens much as it does to the younger ones, we would have called on the retired health practitioners, but that is not an option for us to do that when it comes to this particular disease. We have seen health practitioners dedicating their time across the world, but also dying from COVID-19 because of the risk that is attached to that. So we can then tap on those. When it comes to basic nursing, we have a lot of unemployed citizens of this country that could do basic nursing in general wards if they are given a crash course on doing that. This is not the time to award them a certificate of being an enrolled nurse. It is to try and deal with the problem that we are faced with at this point in time as an emergency. Those are all the ideas that cross my mind when you ask that question. Thank you. Thank you, Chris.
Thank you very much. There was a horrified comment that came through. Did Prof. Pepeta just say that we need to keep social distancing for at least the next 24 months? I would like to know what his thoughts are on when the world will be COVID-free.
There are various predictions, and I will go back to we did really pose a very difficult question as the subject matter for this webinar. This has been touched on by both Darrell and Azwi. We really don't know, and we use retrospective data to inform us about the future, and we are not aware how this pandemic is going to treat us. And it is in the manner in which you feed the data that then you get the predictions that you get. And it's a shifting target. We were estimating peaks around June, and now we're in July, and now we are talking, oh, maybe perhaps August, September. But then we are worried about the second wave that might be coming. And then we are worried about even a third wave that might be so severe that might be coming. The challenge about this particular virus, different to the others, is that its immunogenicity is so low, which might create challenges in terms of creating a vaccine. Because if then you don't have a very good immune response and antibodies that you get that can be pooled, then you are not able to create effective vaccines. And there might be an issue that also the virus is mutating, that is still being studied as to how it changes itself, which also creates issues around vaccine. So the unfortunate bit is that we're going to go through wave 1, and then wave 2 is going to come next year, and then wave 3 is going to come. COVID-19 is here to stay. The only way to contain it is to stick to basic preventive measures. The sooner we do that, the quicker we'll be free of this pandemic. Thank you.
Sure, okay. I think the questions are starting to taper, so we are nearing the end of our webinar. But I just wanted to bring in a few more, about 2 or 3 questions. There's one that says, Darrell, from the model perspective, what might have exposed the Western Cape?
That's an interesting question. I would like to know maybe also Prof. Moronga's take on this. From my perspective, I would say that what would have exposed the Western Cape probably would have been earlier screening and more proactive screening than what was done. I think we went into screening and recording data at a much later stage than what we should have done originally. And I will come back to that when we are given an opportunity to make some closing remarks. But I think the Western Cape, in terms of their predictions, have been probably fairly or more accurate than most. So, and that is because they started recording their data much earlier. So in terms of the actual models, potentially, if we had included some of the comorbidities that we are seeing coming through, together with the screening, then we would have been able to do more accurate predictions for the Western Cape.
Thanks, Darrell. Just as a follow-up on that, there was another question that came that talks to the issue of fake news and unreliable news being highly prevalent at the moment, and that there's almost a sense that we are comparing apples and oranges, in the sense that, do we really know that mortalities during wintertime in South Africa are significantly higher now with COVID around? It seems that we're just talking about COVID and we're not saying same time last year, these are how many South Africans died and this is what they died of. How do we account for that?
I think what is, and I think this is a very, very important question, because something that we are not seeing in the statistics that's being released is the profile of those who died. There's not a detailed analysis of person X passed on and had the following comorbidities, and that is why they passed on. So looking at the statistics around the flu season and all of that, we've never really recorded all of that in so much detail. So I think our overall approach to data in the country is not what it should have been. And COVID has now forced us to consider how we record our data. So we have very little to compare this to. Yes, and there's a lot of fake news and all sorts of statements flying around, and let me not get myself onto the front page of a newspaper in repeating some of those. But I think what is important to say is that from a knowledge perspective, there's a lot of unknowns still. And a lot of what we are hearing is just guessing. As I started out right at the beginning, and I said, remember, a model is only as good as the data that is going into it. And garbage in, garbage out. So if we're not recording accurate data and keeping definitive records of that, we are unable to make accurate predictions and reflect on previous incidences. So I think, and that also speaks to a lesson that we have learned out of this whole situation.
Thank you very much, colleagues. We're now going towards the end of our webinar. The questions are still coming thick and fast, but we did have a certain amount of time set aside for this conversation. I'm sure that the conversations will continue in our private spaces and with all our friends and our families and our colleagues. So what I'm going to do now is to invite my colleagues, the esteemed professors, to give us their closing remarks. So about a minute or so, just to wrap it up and give us your take-home message. So I'll start with Azwi, then Lungile, and then lastly Darrell.
Thank you very much, Kwezi. We are asked in our spaces to educate others with evidence-based model and data so that we can at least counter fake news. And that is what the modeling is all about. However, I think after COVID-19, this attempt to model the COVID-19 should help South Africa with its own problems of HIV, malaria, and the continent with Ebola. I think the expertise that we'll get out of really getting into the habit of modeling and following the rest of the world will help the continent in the end, because we will have other outbreaks that will be continental. And therefore, the expertise that we generate now through the COVID-19 should prevail post-COVID-19. I think one last perhaps point from me is that we need to educate the public, our colleagues, about the importance of physical and social distancing. I think that's very important, including, of course, daily healthy habits that we all need to undertake in our spaces. Thank you very much, Kwezi.
Thank you very much, Azwi, for those closing remarks. Lungile, your take-home message.
Thank you very much, Kwezi, and thank you very much to the audience and their questions as well. Very constructive. I think for me, the take-home message, this pandemic gives us an opportunity to reflect as South Africans and the world. There is no war that has ever been this big, like the one that we are fighting. The enemy that we are fighting is an enemy that no matter what we do, we don't have weapons to kill. You cannot cure COVID-19. Let us stay out of the way of the virus by doing the simplest of measures and ensure that we do not contract the virus. Whilst we do that, this is an opportunity for us to revise as South Africans our own basic health system delivery models and adapt those to ensure our longevity as society. Thank you.
Thank you, Kwezi.
The floor is yours.
So I would like to conclude with 3 takeaway messages. And to me, the first one is be wise, be informed, and be educated. Make sure that you understand what this virus is about. The second is prevention is always better than cure. So in this case, I want to say prevention is also better than being tested. Make sure that you take the necessary precautionary measures, that you do not have to be tested. And then we always have the African saying that it takes a village to raise a child. I want to say that globally, it took a pandemic for us to review our healthcare systems and how we approach healthcare in going forward. It will never, ever be the same. So change is inevitable. And remember, it remains in our hands.
With that, I would like to thank our excellent panel for the time that you took off your busy schedules. You are all dealing with COVID-19 in various capacities. and lending your expertise to where it's needed the most. So thank you very much for taking the time to prepare, to attend, to answer questions, to share with us your thought processes, as well as what you think we can collectively do to beat this pandemic. What has been very clear to me as I listened to all the deliberations and interactions through the questions that came is that the most effective way to beat this pandemic and to slow the spread of the virus is through intentional behavioral change. That is washing our hands frequently as we've been advised, wearing our masks whenever in public, and maintaining a physical distance. The Nelson Mandela University has designed a t-shirt that you see on the screen. It is indeed on our hands. The t-shirt is available at the university shop, both with short sleeve and long sleeve options. So please see if you can get one for yourselves. I would like to thank everyone for a most interactive session, especially our attendees that kept the questions coming. I am sorry that we could not get to all your questions, but I hope you enjoyed this informative session as much as I did moderating it. Take care and stay safe.